I think we'll get started. Hi, everyone, and thank you for calling into our webinar. This is on value in acute care surgery, and I'll be moderating the webinar together with Patricia, Ayoung, Chee, who is with me on the call here. And we are very happy to have our guest speaker, Dr. Jason Smith, with us here as well. I think many of him know you as both known trauma surgeon and C-suite executive, now CEO of the University of Louisville Health System. And we'll talk about what value in acute care surgery means, how we provide value. We'll also hopefully address how you can recognize the value that you as individual acute care surgeon provide, which I think is important when we're talking about contract negotiations, understanding your worth. So we'll hopefully address all that today. First, a CME disclaimer and notice. AAST has told us that they no longer offer CME for live grand rounds. But if this gets archived, you might be able to access it via the archive, and then there will be information about how to claim CME by logging onto the AAST website. The goals today is to hopefully explain to you what value means, especially in the healthcare setting, and where we stand with the whole concept of value-based care as opposed to the traditional fee-for-service system in the U.S. healthcare system. You will hear, especially from Tricia, about how different stakeholders have different ideas of what value in the healthcare system is and what high value or good value is. I'll tell you more about how to know your value, how to know the value that acute care surgeons provide to patients, to institutions. Much of that goes beyond traditional assessments of that we might think of like hospital charges or RVUs. And then most importantly, throughout the presentation and towards the end, we'll ask you a lot of questions from Dr. Smith to kind of understand how that translates into practice, so you don't just get the theoretical knowledge about this, but really also understand how does this get applied when you talk to somebody who knows both how administration and the C-suite thinks, but who is also a clinically practicing trauma surgeon. If you have any questions, you cannot unmute yourself, but you can type questions into, I think, the chat box or the question window. And what we'll do is we'll keep an eye on it, and we might either address the questions at the very end, or we'll go through them if they fit to the actual slide that we're on. So first, to the introductions, I will let everyone introduce themselves, and we'll start with Tricia.
Hi, my name is Patricia Ayoung. I am, I guess now a professor at Morehouse School of Medicine in the Department of Surgery. I'm one of the trauma surgeons at Grady, and I do quality for Grady.
And then we got Jason.
Yeah, my name is Jason Smith. I am the newly elected CEO of U of O Health. I've been the Chief Clinical Officer of U of O Health for the healthcare system since 19, and I was the CMO of a hospital, CMIO before that. I also still fill in division chief roles from time to time on the academic side. And because our trauma schedule was made before I got my CEO role, I will be taking trauma call tomorrow night. So if you're in Louisville, feel free to stop by and see me. I'll be in the resuscitation bay starting at 5.
And I think I should not hide the fact that what you see there under Jason's picture is really only about half of his email signature and titles. And yesterday when we finalized the slides, he asked to cut most of it off. But there is a lot more that he can boast in terms of roles and accolades. And my name is Stefan Leichtle. I'm an associate professor of medical education at UVA and trauma surgeon at the Nova Fairfax Medical Campus in Falls Church, just outside of DC. Now, getting started, when you think about the term value, that is really not anything that is specific to medicine or to healthcare, but we actually use it a lot more in our everyday language. When you look at what value, how it's defined in the dictionary, and I pulled up Merriam-Webster here, it is mostly something financial. It is the monetary worth of anything, but there's also the idea of a fair return or equivalent return that you get for your investment, be it your effort, be it your money. And that's really what most definitions, even if you look at other dictionaries, what they aim towards. And this whole idea of the fair value and equivalence is something that'll become really important as we're looking at the US healthcare system just a couple of slides down from now. Now, in the healthcare system or in healthcare setting, I think the most common or best known and established somewhat definition of value is Michael Porter's value equation. Michael Porter is an economist that is teaching at Harvard Business School, and he came up with this definition with that equation in 2010, so quite a while ago now. And essentially what it says is that value is quality divided by cost. It's not really meant to be a mathematical equation, but the idea really behind it is that high quality, the highest quality of care that you as clinician can provide, that can be somewhat diminished if you have uncontrolled or excessive cost. That cost really drags down your value relative to the quality. What's also important, as very brief excursion at this point, is when we talk about cost, what we often think of is the price. And the price is really, that's the sticker price. Those are the hospital charges. That's what you often also read somewhat unfavorable articles in the newspaper when you read about the Tylenol tablet that costs $600 at the health system, or you look at the out-of-pocket bill the patient got for $30,000 for anesthesia. That is the price. And that is really not so much reflecting what the hospital actually has to pay for it and what the costs are, but this is a result of negotiation of contracts, insurance companies. What we care about in this value definition is the actual cost, what it really actually costs the health system to provide care to the patient. And this summary that you see there, that brief comparison, is from the AAST bulletin from a couple of years ago and kind of nicely conveys that. And the last comment to make about this value equation is that from the original form that you've seen from 2010, quality per cost expended, it's been addended and modified since then with the idea that really quality by cost does not fully reflect what is going on, but we also need to think about what access do patients actually have. The highest quality of care does not help your patient if they cannot access healthcare, either because they have no hospital nearby and they simply can't get to medical care, or because they have no insurance and the costs are so prohibitive that they can't get to care. And similarly, patients may not fully understand what high quality is from our clinical perspective, but they experience the kind of service they experience. Were they treated well? Did they get the attention they deserved? Did physicians and other clinicians explain things to them? So the idea that quality really needs to be added, service and access per cost expended, to fully capture the value. With that, I'll hand over to Patricia to get to the point of why it's so important to look at value, especially in our US healthcare system.
Right. And I mean, that answer might seem obvious, that value is how we all make decisions, but it's really important to focus on it. As spending increases, we automatically decrease the value we are getting unless we increase the quality, service, and access at a proportional rate. Currently, the US spends $4 trillion, 17% of our GDP, on healthcare. Based on historical trends, the spending will continue to increase, and compared to other developed nations, we spend twice as much as they do on healthcare. So the question then is, are we actually getting twice as much quality? Next slide. If we use life expectancy as a measure of quality, the resounding answer is no. Life expectancy in the US is on average 4 to 5 years less than in other developed nations. And this difference is exacerbated if we look in more detail by socioeconomic status and by geography. Next slide. We get the same picture if we use other measures of the numerator in the value equation. While our denominator, cost, is higher than the other countries, the US ranks lowest in the domains of access, outcomes, equity, and administrative efficiency. We are not getting our value for money as we are spending. So why are we spending all of this money? Next slide. This JAMA article really discusses the various domains of waste and estimates that about a quarter of total healthcare spending, $760 to $935 billion, are spent in failure of care coordination, fraud and abuse, overtreatment or low-value care. And anyone else thinking about MRI to clear cervical spines in this category, raise your hand. Failure of care delivery, pricing failures, and administrative complexity. Remember, we are 9th in administrative efficiency compared to the UK, Australia, New Zealand, France, Canada, the Netherlands, Sweden, and Germany. It would be nice if we could say that the administrative complexity leads to better access to care, but we are ranked 10th in that domain. Given that what looked like a simple equation to calculate value is not so simple, Dr. Smith, I'd like to ask you, where do you think the value lies and how do we find it?
Yeah, Tricia, I mean, that's a good question. And I think, if I look at it, really, I guess there's a couple ideas that you want to bring forward. I think, the idea, and I'll challenge these at the end, the idea that you've kind of got a pyramid with cost, access, and quality in that pyramid, and that you can get 2 positive results, but you can't get 3 positive results, or otherwise the pyramid won't stand. And so what I mean that is, traditionally, if you want quality to go up and access to go up, cost is also going to go up. If you want cost to go down, then you're going to have to limit access, you're going to have to limit quality in order to make that happen. And if you ever wonder across the healthcare systems why we have things like copays, you can go back to the Rand experiments. The Rand Corporation, ran a series of experiments in the late 70s, early 80s that looked at people that got insurances with a small copay, a high copay, no copay. And what you found is that, surprise, surprise, when you don't have some skin in the game, for lack of a better term, folks are accessing healthcare, and they would access it to the detriment of the system in themselves. They actually had a reduction in quality. They had much higher rates of utilization. They had longer waits for different things. And so you have to find that balance, right? And so when you start talking about, figuring this out, it's a balance between those 3 things that you put up. I think the other question is, when you define value, my definition of value and your definition of value may be very different. And it goes back to, what do I define as quality? What do I define as cost? And I always say I use the example like I do for shock, right? And it's do the geography test first. Is, whenever you get a patient in shock, you need to look at your feet and see where you're standing, right? Because if you're standing in the trauma bay, it's the reason for shock is most likely hemorrhagic shock. If you're standing in the CVICU, the reason for shock is probably most likely cardiogenic or something along those lines. And I think value is a little bit, when we're trying to tell our story about what value means for acute care surgery, is I need to look and see where I'm standing. If I'm standing in front of the CFO, I need to be able to talk in the language of the CFO. We're going to start talking about cost and dollars and halo effects and things like that. If I'm standing in my department chair's office, then we're going to start talking about quality and what does quality mean to defining value. So it's a little more nebulous and fluid than I think people want to hear. But I also think that, if and when you define that, it's a remarkable change in all of the discussions you have, if you are willing to take the time to define what each one of those things mean.
Yeah.
Great, thanks so much. I think it conveys that, unfortunately, value is not this easy one-term definition that is universal. That makes it hard to measure. It makes it hard to aim for it. And I think that answers the question why still so much what we do in healthcare is fee for service, because it's easy to measure. This is what I did. I did the procedure. I saw the patient in clinic. Much, much harder to even look at the outcome, the quality, and even harder to look at this somewhat nebulous value concept.
No, absolutely. And I think, easy things to measure are easy things to mark, for lack of a better term. And as we enter into the NFL and football season and the like, or if you're an English Premier League fan like myself, you're in a soccer season, the value of a player is dependent on the market that they're in. And I may highly value somebody, another team may not. And so I may go sign him and pay more money for that person, because that to me brings more value to my team and others. I think our job is to try and portray ourselves in the most important ways possible of being a value to the organization. And again, that will change probably depending on where you're at. And it's not always as simple as saying, well, look at the work RVUs I produce.
Mm-hmm. Well, I think this is kind of a good next step, is to look at why you listening to us here should care about that. Because right now we've talked a lot about the maybe the overall the GDP in the US, the national healthcare costs, and I think it's sometimes tempting and very understandable to say, I'm a clinician, I'm a trauma surgeon. All I care about is that I can do a good job and provide the best care to the patient in front of me. Why do I care about how much waste happens in the healthcare system? It doesn't happen, it's not me wasting anything. I like to believe. Why do I need to care about it? And I think the reason is that in 2025, you can't ignore those considerations anymore because they are not ignoring us and they are not ignoring our patients. And one of the reasons why we as acute care surgeons especially have to care about this, maybe more so than our colleagues in plastic surgery or other surgical subspecialties, is that ACS has a very, very large footprint. There's a study that by now is actually a decade old, but already at the time, 20% of all hospital inpatient admissions have an ACS diagnosis. That is, they're either a trauma patient or they have an EGS condition, which is exactly what you think it is: appendix, gallbladder, hernia, bowel perforation. And that is, again, 2014 data. And we know that since then, that has just gotten much more. At the time already, those 20% of patients accounted for 25% of total inpatient costs. And what you see here is not just a staggering number of $85.8 billion in costs, which it's so high, I can't even wrap my head around what that means, right? But what you see is clearly the imbalance here, that you already have more cost based on percentage to the number of patients. And we also know that since 2014, our patients have gotten much older. They've gotten sicker. When I think of my EGS patients, I can barely see anybody on my EGS list who doesn't take 5 home medications and has at least half a dozen comorbidities. So that cost and ratio has just gotten up since then. So we have a large part of those costs. Now, somewhat also related to that, of all those costs, hospital, clinic, and physician services make up about 50% of those $4 trillion of annual healthcare costs. Now, I think it is important to emphasize, we're all clinicians on the call here, the physician salaries are actually the smallest part of all this. But the problem is, if you get lumped into this group of hospital, clinic, physician services, making up to more than $2 trillion of annual healthcare cost, we are a favorite target for policy efforts and legislation to curb the expenditures in the US healthcare system. And I think that is something anybody that is listening in that's participated in the ACS Leadership and Advocacy Summit has gone to the Hill by going into some senator's office and talking about how your $400,000, $500,000, or $600,000 salary a year is just, not a fair reflection of the work you do and how your reimbursement has gone down. You're not making friends, right? You're not getting a lot of sympathy there. And that is part of the problem, that it's very hard for us to argue publicly about the cost when people very quickly look at our reimbursement that does put us in a very high income category. Similarly, being acute care surgeons and trauma surgeons, our patients often are either underinsured or uninsured. So the hospital might get less money for the patients we see than who our colorectal surgery colleagues see or our vascular surgery colleagues see. So our reimbursement is very sensitive to case and payer mix. What it means, if you're bringing in less money to the hospital because of your patient population, if you're RVU based, your RVU target will go up. You might have to take more calls. And I think we have a lot of data out there now that directly links the number of calls we do per month, the call frequency, the work hours. That is directly related to the pervasive burnout problem that we have among trauma and acute care surgeons. If that is not bad enough, how it affects us, there is a lot of literature by now on the impact on our patients. And I think this is a good time to highlight the work of one of our colleagues on the Health Economics Committee, John Scott. He's at Harborview, and he's been studying that idea of financial toxicity and financial hardship for multiple years. And based on those studies, we can find that more than 70% of patients that experience trauma and have no insurance, and even up to 10% of patients with insurance, are at risk of catastrophic health expenditures following trauma. And I think that's a concerning number, that even with insurance, you're just one car crash or bicycle accident away from potentially catastrophic health expenditures. Insured patients that have trauma, they face an average of $5,000 of out-of-pocket spending. Now, as an attending surgeon, that's not an amount of money that concerns me personally, but I think if we have any residents, for example, or fellows listening in, and you think about your salary, $5,000 is a lot, and it certainly is a lot for the average American when you look at the average household income in the US. What's also increasingly, I think, something we realize, that getting our patient out of the hospital successfully without them dying or having a PE or being in the ICU with pneumonia, that's really only half or maybe less of the game. Up to 40% of trauma patients are unable to work after trauma, even 2 years after traumatic injury. That's a study that was done a couple of years ago by all the trauma centers in the Boston region. And when you look at all that, now those $5,000 out-of-pocket spending and those health expenditures are not just a one-time problem, but they actually become a real issue that is also now connected to loss of a job, loss of health insurance, and no further income. So I think overall, hopefully those last couple of slides showed you that you may or may not care that much about the GDP and the cost of healthcare in relation to the GDP, but that whole topic and those problems really directly affect us and they directly affect our patients. And with that,
So in an effort,
Patricia.
yep. So in an effort to provide some background information that people can refer to have, a basic foundation, a little base knowledge on value, the AAST Healthcare Economics Committee published a series of papers on value in acute care surgery. The first two focused on quantifying the cost and defining quality. As we said earlier, these are two domains that are not always easy to plug numbers into. Cost analysis methods can range from detailed microcosting and time-driven, activity-based costing to less complex gross and expenditure-based approaches. Objective quality is based on outcome measures from both administrative and clinical registry databases, but risk stratification is key to ensuring these objective measures compare similar populations across diseases and procedures. Quality metrics also have started to incorporate domains for patient-reported outcomes, that service aspect that we talked about, and then financial well-being as we move towards recentering on the patient. Dr. Smith, another quick question. In your role as CEO when you were Chief Clinical Officer, what does it look like to measure cost and quality on a larger scale at the hospital level?
Yeah, no, and I will say this is where the data geek in me and the practical aspects of managing and monitoring this kind of fall apart sometimes. Ideally, if you're asking me what I would love to see would be really true micro cost accounting, where you can take all of the direct costs associated with a procedure, be that all the equipment, all the consumables. You marry that with the amount of time in the operating room and the anesthesia salaries and the pharmacy costs, and you come up with a really good data regarding the cost. That's almost impossible to do. I'll just be clear to everyone. There are places that do it better than others. You can do it for certain procedures, but if you're saying, hey, I want to look at everything in that regard, it's probably not useful. When I tell people we want to define costs, what I want to say is we are going to agree on an imperfect number from the start, okay? So whatever we're going to do, we're going to look at the cost of a new service line, of a procedure, whatever. Let you and I come to an agreement on what we're going to call that. This is how we will define it, and then no backing out. And what we can't do, right, is we're going to be transparent about the number. We're going to define that number, but at the end of it, you can't say to me, well, you know what, that's just not really real. That doesn't, all this downstream revenue is not accounted for. So you got to be consistent, right? And so, being comfortable with some of the vagueness associated with some of these things is really important for defining that. And I think if you get to some of those, you can really make some nice headway as long as you're transparent and consistent with the way you apply some of those different metrics, for sure.
Yeah, and I think we'll talk a little bit more about consistency and transparency when we start talking about some of those value-based payment models.
Sure.
Next slide. So as we were saying earlier, the value is in the eye of the beholder. If you're the patient, next slide, proximity to care may not be worth traveling for a 1 to 2% reduction in a quality measure that is already less likely to happen or that you may not feel or experience as the patient. For society, we have to remember that healthcare finances and healthcare economics are a social science. They are not the same. Outcomes such as restoration of function and functional independence, as well as return to work, may have a higher weighted benefit than from an individual clinician, organization, or payer perspective. With respect to healthcare organizations and payers, we might be looking at the same coin from different sides. Next slide. Value-based purchasing programs were implemented in 2013 as part of the 2010 Affordable Care Act. The impetus was the projected growth of healthcare spending, particularly in surgical care, that was threatening the financial health of Medicare. The goal of these value-based payment programs, such as payment bundling and accountable care organizations, was to reduce expenditures while maintaining quality. This is also around the same time that choosing wisely and the phrases such as low-value care came into use. Examples of such programs include hospital value-based payment programs that assess hospital performance in safety, clinical care, efficiency, and care coordination. Hospital readmissions reduction program was also introduced, and that includes financial penalties to hospitals for excessive readmissions after coronary artery bypass graft and total hip and knee arthroplasties. And then there's the surgical bundle payment, otherwise known as global payments. Of note, Medicare is not the only payer with value-based purchasing, and approximately 1/3 of commercial payer payments use an alternative payment model that is based in value. Next slide. So how do we possibly get everyone to align? We have 4 or 5 different stakeholders, and they all vary based on their geography and where you are. And some of the questions of, transparency, defining exactly what we are looking at. Will shared decision-making help with aligning the patient, the provider, as a representative of the organization, the provider being more involved within the organization and how these decisions get made, then being able to be better equipped to be a representative for the organization? Does hospital compare give enough data for patients to interpret and adequately compare hospitals to balance the pricing that patients will face, assuming that the costs within transparent pricing are accurate and interpretable to the patients? Are we as providers adequately clear and transparent in our communications with patients regarding risks and benefits of surgical procedures and listing the alternatives? Is an approach akin to best case, worst case applicable, even if we are not talking about end of life goals, but just about the goals for a particular episode of care? I think more things to come. The thing to note about all of this is none of the value-based purchasing models directly affect acute care surgery diagnoses. And so it's sort of interesting to see. Just to mention, though, the Michigan Collaborative and now the Georgia Collaborative for Trauma Centers is introducing some pay for performance-based payment models within their reimbursement to trauma centers.
And I do think maybe worth mentioning is that we will, I think, be affected by the more recently introduced team model that CMS has introduced. It affects major bowel resection. So I think if not trauma, I think trauma might be excluded, but EGS will certainly be involved in that. And I think maybe something for Jason, any update there? I think we are affected now with that, right? You care about those things now even more, I think, than just as a surgeon, as trauma surgeon.
Oh, sure. Well, I mean, so, I'll back up one step. So anytime you're talking about alternative pay or alternative, payment models, value-based purchasing, value-based care, I think there's 2 things you have to talk about. So the first one is I'm going to give you something called moral hazard. For those that don't know what that is, I'll give you an example. Okay. Imagine that I'm the attending on call and I've got my fellows and residents and we're all sitting down to figure out what we're going to have for dinner. Now, one, that's a disaster because we're never going to actually make it through dinner if we do that. But let's assume that we've got it. If the answer is that, we're all going to just pay for our own meals, we'll go to the cafeteria and we're eating, maybe a salad bar and chicken strips, right? Nothing wrong with salad bar and chicken strips, perfectly nutritious and no problem. But if I'm paying, what do you think we're getting? Well, we're not going to the cafeteria, right? So we're ordering in, Mediterranean food or something. And I think therein lies the issue is that it's not necessarily, I think when it gets put out to other folks, it's easy to say, hey, if I'm treating cancer for me, I want everything done. But if it's for you, maybe we don't need to do everything. Let's just use evidence. Some things go out the window when we start to talk about the morality associated with the individual versus some of the large things. So be aware of that. And I think, too, the bigger thing that you have to realize when we start talking about value-based purchasing and value-based care is assigning the risk associated with managing that care. The biggest concern about the value-based purchasing models is it takes the risk of managing those patients out of the insurance company, puts it squarely on the healthcare system's shoulders. Now, if you do well, you may be able to be reimbursed, but if you don't do well, you're going to have a reduction in reimbursement and say, I've got to take a patient, and they've got to be in the hospital an extra day or two. You add that up over the course of a year or 1,000 patients or this, that, and the other, and you can quickly lose a significant amount of money on these value-based purchasing contracts. And I think from our perspective, that's things you have to realize, is that management of moral hazard and management of risk really come into all of these models, and realize, and ask yourself the question, where does the risk lie and where does the money lie? Now, with that being said, this is coming for all of us. So this horse is well and truly out of the barn. We have been somewhat protected in general surgery, definitely not protected in all surgery. Orthopedics has hit this. Even neurosurgery is getting hit with this now. And I think it's imperative that you've set up things in and around your system to be able to manage all of the operations of the healthcare system dedicated to the patient. Now, is that good? I mean, I have a surgeon will tell you, yeah, it's absolutely good. I think, better throughput, more tried and true methods of managing that care is important. We deliver cost-effective care. That's an important thing to consider as well. But at the end of the day, I remind folks that you have to manage the variability, and the risk for managing the variability of these human patients fits squarely on the shoulders of the people signing into these value-based purchasing or value-based care contracts. So it's coming. And Stefan, you are completely correct. It is coming for bowel resection, and it will work its way into, already in colon. It's going to be in and around robotic procedures soon, all robotic procedures. So, when we start talking about Da Vinci and the likes with Intuitive, this will be the future, and this is one of the ways that insurance companies and CMS has decided we're going to help control cost, is by looking at these bundled payments, for lack of a better term.
Now, thanks. And I think it goes back to the point we made earlier. At this stage, we can't ignore those considerations anymore because they're no longer ignoring us. And I think anybody who is not a few years from retirement will not be able to escape that.
No, and I think, we do ourselves and our patients a disservice if we don't consider the cost of care that we are rendering in our overall equation, and I'll leave this to, if, let's say I do something and there's high cost, but the insurance company denies it, and it's going to fall to the patient, is that one, well and truly needed? Two, we discuss the ramifications of that bill with the patient before doing it. Again, it goes back to transparency, and it's no longer acceptable to say, well, you know what, I'm just going to do the best for my patient, and I don't care what it costs, because that's neglecting, and the great, manuscript up there, that's neglecting the aftermath of the care you provide to that patient. And there are economic impacts of that for those patients that can last for years.
Yeah, the best example I had of that was during CODA, when we were discussing with patients antibiotics versus appendicitis in New York. We had a lot of bellboys, and they would say, if you tell me that I cannot do a heavy lifting for 4 weeks or even 2 weeks after this, I'd rather take the chance of antibiotics working, because then I can work. Because not being able to show up to work even for 2 weeks was a real problem.
Oh, absolutely. And I think, we have to begin to weigh this in the same way we would look at any outcome that we have. And, I talk about this in my own healthcare system, is we need to talk about effectiveness. It's comparing the outcomes of the procedures, the cost of the procedures. And, I always say, don't spend $5 when $2 will get you the same result. And we have to be honest with ourselves. We are technology junkies. Now, some technology is good, right? I mean, that is how we push forward the surgical care of our patients. I get that. However, not all technology will lead to better results. And I think I will tell you, and I've given this talk about robotic surgery versus laparoscopic surgery. When robotic surgery kicked off, and we were talking about transitioning from open procedures like prostatectomies and our gynecology procedures in the pelvis, open procedures to robotic procedures, that's a no-brainer. That is absolutely a no-brainer, right? You're saving pain, you're saving time in the hospital, easier and better recoveries, fewer complications. I get that. But if you're saying, hey, we're switching from laparoscopic procedures to robotic procedures, that's a very different value proposition, right? And I'm not saying it might not be the way we go. And I think there's lots of reasons we can talk about why that might be useful. But it's very important to understand that just because a value proposition worked for one thing, the comparative group may be very, very different. And a robotic lap chole versus a robotic chole versus a lap chole is a different value proposition for patients, for about 90 to 95% of those patients getting one of those, robotic inguinal hernias versus lap inguinal hernias. You can name the gamut that you have to kind of really look at, is this the best for our patients, and is this where we need to be putting our dollars?
We actually have a couple of questions, Stefan, about alternative payment methods. So Dr. Chernock is asking, when talking about value-based bundle care, does complexity of the case, or I guess the patient as well, come into play, or is it simply the procedure that was done and XYZ are the outcomes?
Yeah, no, I think it's great question. It's actually, there's two different models, and some are different. So let's take the I don't care about the complexity of the procedure model. The best indication for that is total knees or total joints and orthopedics. If I look at total knees and total joints and orthopedics, the value-based contracts, by and large, do not care about the severity of illness or the comorbid factors associated with those patients, right? What they're really looking at is high turnaround time. Do you have the processes in place for a low number of complications? In that system, then you've got to very specifically screen for those patients and bring those patients into your systems that can make that a good value proposition. Because if I start bringing in patients that may be in the hospital 6 or 7 days, or they've got a lot of comorbidities, and maybe I'm doing a total knee and I'm going to have to do this, open versus arthroscopically, it just quickly falls apart. And so that's one model. If I look at trying to figure out, hey, is complexity kind of pay in? Really, I tell people, there's no CC or MCC diagnosis associated with value-based purchasing contracts, right? And so understanding that when patients, one, opt out, two, what is the language for the opt-out associated with that? And three, looking at a very narrow window of what I can and can't do on a value-based contract is super important for managing these. And again, folks have done this, orthopedics, neurosurgery, ENT, plastics, you name it. It has come for all of these specialties more in the elective world than what we deal with oftentimes, but it is still there. And I can only imagine a time in the future where, let's say we code something as a level 1 trauma, and there's a code associated with that, and you're going to get a specific reimbursement for that regardless of the injuries. I mean, imagine how difficult that would be to manage in a healthcare system. And I think that is something that I can absolutely see happening sometime in the future.
And I think somewhat related to what you briefly brought up is another question we have from Edward Kelly on the topic of moral risk. Does value-based system reward practices that screen out high-risk patients? And I do think that is certainly a potential risk. I think there were some examples about 1.5 decades ago in I think in New York State when the STS and thoracic and cardiac surgery got introduced, and people deliberately sent their patients to the ED so they were classified as emergency, would increase your expected risk. So then your observed risk and your O/E ratio was more favorable. And I think what you mentioned, when you have procedures where complexity does not get accounted for, like in the knee replacements you mentioned, if you do a knee replacement on somebody who's cirrhotic and has uncontrolled diabetes, I mean, putting aside that maybe it is indeed not a good idea to do a knee replacement on that patient, but you're obviously picking somebody who you expect to recover quickly and have no complications. Is that kind of a right assessment?
Yeah, no, absolutely correct. And you got into a little bit. This has been the knock against hospital compare since its inception with CMS. And if you look at safety net hospitals and large academic institutions who will function as a safety net hospital, There's pretty good data out now that says hospital compare disenfranchises those types of facilities. Now, there's a multitude of reasons for that, and some of them, are the faults of the healthcare systems as opposed to the ranking system themselves. But also, a lot of that is related to your conglomerating patients that are more prone to getting complications. They have fewer social support mechanisms in place in single institutions, but you're not changing the grading scales or support given comparing that to maybe a private practice hospital. And it's very important for us because that's where a lot of us practice, right? I mean, if you think about trauma centers, we are in general the safety net receiving hospitals for the communities that we serve. And so understanding, what those impacts mean to me, and aside from the fact that Hospital Compare still has data from 2022 in there, it, it disenfranchises some of these, newer systems, safety net hospitals, patients that get quaternary referral systems really have to put a lot of effort into maintaining their quality outcomes in and around Hospital Compare.
Yeah.
And I think it's a good segue to talk about the value of an acute care surgery service and the value of an individual acute care surgeon, and the challenge maybe to actually convey that value either to the larger system, as we just talked about, or even to your own hospital administration. And this goes back to a paper that is the last part of this 4-part series on value in acute care surgery about the actual economic value to the hospital system. And this is a table that you'll find in that article that kind of breaks down the ways that acute care surgeons provide value that go beyond what is easy to measure. It's easy to measure the charges you bring in the OR, the RVUs you produce, the clinic visits, and we're doing part of that, especially in situations where some of us have elective practices. But when you think about what you do, and I always like to say, when you think of your last call, be it a 24-hour call or be it a 12 or 15-hour call that you alternate with your colleagues, all the things you do and how many of those things can you go to the EMR and put an adequate billing code in there? And how many of those things you either just can't bill for at all, or you don't do it because you're too busy and it's not worth the effort. And sometimes conveying what you did in those 24 hours of busy call can be hard. And one defining aspect of us as acute care surgeons is this 24-hour availability. And that really, I think, makes us part of hospital infrastructure. Without the hospital just can't run. It makes us quite a bit more like our emergency medicine colleagues or anesthesia colleagues at a big level 1 trauma center that are also there all night waiting for whatever comes in. For the hospital, what it means having this 24-hour availability from a purely financial perspective is that us being there allows for surgical rescue, not just of our patients or the trauma patient coming in, but anybody who had an operation throughout the day with our surgical colleagues, anybody who maybe is losing their trach in the medical ICU and needs a surgical airway. And being on top of that and rescuing this patient is much more cost effective than dealing with the fallout on the complication. By being in-house 24/7, it does also allow for revenue generation outside of traditional working hours. When I look at the EMR, I pretty much never see any subspecialty notes at 11 p.m. or 2 in the morning, but I very much see a lot of admission H&Ps and consult notes from my trauma surgery colleagues at those times of the day. And that is just simply more time in the hospital that you can bill for. And there is decent data both in trauma, but especially in EGS, that being in-house 24/7, it decreases your length of stay. And I think that's kind of a no-brainer. The appendix that comes in at 11 p.m. gets the operation and often goes home from PACU and doesn't even get admitted, as opposed to admission and then adding on to the next day OR schedule, and it increases the throughput. When we look at quality as a result of this 24-hour availability, surgical rescue is one of the characteristics of a high reliability organization, which I think most large hospital systems strive to be. We all know that calling us early rather than when the lactate is 15 prevents complications and improves patient outcomes. And our patients simply wait less long if there's an acute care surgeon in the hospital 24/7. For the patients and for our colleagues, there also is some good data, especially from about 10, 15 years ago when acute care surgery got established, that having an acute care surgeon that keeps our colorectal surgery colleague, bariatric surgery colleague, or general surgeon out of the hospital 11 p.m. for emergencies it improves their satisfaction, and it also improves our satisfaction to operate. And especially when we think of trauma that might not be very operative in many scenarios, it allows us to be more in the OR. And patients obviously also enjoy not being admitted and waiting for the operation the next day, but having it done quickly and being discharged. Another aspect, when we look at the EGS component of what we do, again, there's pretty good data that having an EGS service increases the efficiency of our EGS patients, but even the other services. Because if your general surgeon has an OR day of elective hernia scheduled, and now they have to come in the middle of the night because there's no acute care surgeon, that disrupts their entire operative day after that. And I think a big portion that is often neglected in both trauma and EGS is the amount of revenue that we bring in with our trauma patients. If you think of how many operations our orthopedic surgery colleagues do on our trauma patients, and I think at least in every place I've been so far, they're not admitting the patient, right? That's a trauma patient that's on the trauma service, but they're getting to do the procedures. Same applies to neurosurgery. And there are actually several papers that are based on TQIP that provide a tremendous amount of financial value that we're essentially teeing up for our neurosurgery, especially and orthopedic surgery colleagues. Similarly, the quality of care, getting access to care timely and equitably and efficiently is part of high quality care, and we're offloading a lot of call burden and workload for other services. And similarly to when we think about our trainees, I think at most systems that have a busy trauma surgery service, EGS and trauma are among the busiest operative services for the residents when you think about where they rotate, where they get their experience. When we look at surgical critical care, I think it's important, especially these days where critical care maybe moves in some situations more to our non-surgical colleagues. Being a surgical intensivist keeps critical care, including the critical care billing, in the surgery department, in our division, and I think that's important. And we all feel that, especially for complex surgical patients, we are better understanding post-op complications, hemorrhage, trauma resuscitation. And I think those parts are hugely unique to surgical critical care. And I think circling back to COVID, which seems like a lifetime ago now, but really was just about 4 years ago, 5 years ago, we were pretty much the only physicians that were running in the hospital up and down because we could operate when it was needed, but we could also manage the ventilator in the medical ICU or in the general ICU for anybody with COVID ARDS and COVID pneumonia. And that degree of flexibility of being surgical intensivists and surgeons, that is unique and that is a huge value. And last but not least, when we think about the trauma system, trauma does pay, at least in states that do support trauma centers financially. And we've seen that after the Affordable Care Act in 2010, the proliferation of trauma centers that has happened because you do get generous support depending on your state situation. And that even aside, just the return of investment of a trauma center is tremendous. There's one paper that we're citing in our article there from the state of Arkansas, and they invested $9 million into developing their trauma system, and they had a 9 times return of investment over the subsequent years in terms of economic engagement and patient care by investing in the service. And last but not least, trauma is very often, it enhances your reputation. I think the billboards for Level 1 Trauma Center, we see them in many states. Very often when we do Stop the Bleed at the various state capitals, it's a good way of promoting trauma surgery and acute care surgery as a specialty. And all those are aspects that hospitals benefit from us as acute care surgeons. And I think most of what you just listened to does not directly produce RVUs. And I think that is the key. When we often get valued by that alone, we're missing out a lot of these aspects, and writing them down and being aware of them is really important. Now, with that, we obviously went into a couple of questions already, and I see another question coming in here that we can address, and then we're open for any additional questions with Jason Smith, and we got a few for him too. So I think I'll start with the one Q&A we have from the audience, and then Trisha, if you want to go through our questions with Jason. From the audience, from Eduardo Smith Singares, we have: how would you propose to manage and mitigate the fragmentation of care when it pertains to acute care surgery? And I would love to see if I'll ask you guys. I think I could go in a couple of different directions with that. So maybe Eduardo, you can type in kind of one more comment or addendum, or Jason, you unmuted yourself. You look like you already have an answer and know
Well,
what
I
it
mean,
is.
I guess, the model of acute care surgery is the ultimate non-fragmentation model, right? I mean, that's the whole purpose of what we're trying to do is, um, I'll uh, use one of our great colleagues examples of be a spork, and the answer is that's kind of what we are. We may not be the absolute best at anything, although I think we are in some areas, but we can absolutely do everything. And I think that's the model is, whether you're in the ED, the trauma bay, the operating room, the ICU, the wards, the clinic, what have you, name a role that the trauma/acute care surgeon can't fulfill. And, I think that's when we start talking about fragmentation of services, that's our role in that is to maintain that coherency and be that generalist in a world of specialists, right? There's a great book, about versatility, and that's where the idea of be a spork comes from. But that's really our goal. And I think if you look at teams and the structure of teams, those that have a generalist on it that acts as the glue man, and the old team, right? The team idea, that's where our utility is, and that's where our importance lies.
Yeah, I think sometimes in the ICU, I get questions from trainees and frontline providers. Why are we making all the phone calls and coordinating? And I have to remind them, if you were billing, that's actually part of a billable critical care procedure to coordinate care.
Yeah. I think it's a good point. I also I like the spork analogy. At the same time, I think if you want to be slightly cynical about it, you could also say, I think there's a reason though. Everybody has a fork and a knife right in their silverware closet, but few people actually have a spork or value a spork. And I think that is constantly a little bit of the challenge. And I know we talked about that briefly before. This idea that on one hand we one of the big advantages of acute care surgery is that we can do maybe not everything, but almost everything within our specialty designation. But at the same time, I think the risk also is that we are everything to everyone. And if you're everything to everyone, it's also very easy, I think, to get stretched very thin and not get the recognition and, quite frankly, financial reward that you deserve for being that spork, because the classic fork is just a lot shinier. To stick with that analogy.
Sure. Right. I mean, no one wants a spork unless you don't have a spoon or you don't have a fork or you don't want to pay for all three. Right. So, I mean, I get that. And I think, we talked about, Tricia, Stefan, we talked about this and kind of the lead up to this is, we still, we still have a problem a bit in acute care surgery of defining ourselves. We're doing better, but, it's been a long time coming to the definition of who or what we are. And we still have a little bit of an identity crisis there. And until we do that, we're going to have a hard time describing that to others. And so I think we just need to recognize that and either, accept it or try and reframe what we are in kind of the more modern ideas.
Yeah.
Now to make sure that we get all the audience questions, we have another one from Sri Harsha Gumadi. Are trauma divisions and trauma surgeons credited for trauma activation fees, justifying additional value in addition to their direct work RVU generation?
Yeah, in general, no. I mean, the trauma activation fee is to support, what we talk about being ready 24/7, right? So the trauma activation fee in its, I will say original form was to support hospitals that are putting infrastructure in place for being ready 24/7 that may or may not ever see a patient, right? And so there's no billable service coming in, but I still have to be there, and anesthesia still has to be there, and we have to have so much stuff available for a trauma patient that comes through. So that's where it comes from, and that would directly go back into the hospital system/service line, as opposed to be directly related to a work RVU. And I'll caution everyone. We talk about work RVUs and the like, and I think if you look at practice plans, if you've seen one, you've seen one. And if we had a good practice plan out there, we would all use it instead of each one having our own separate practice plan and all the nuances associated with that. The best ones will have a mix of, what I'll call defined category support, meaning for being a good citizen of the hospital, being on call for trauma and things like that, but also have a component related to work RVUs. I think those are probably the best. But there's multiple ways to get to that particular reimbursement or work RVU targets associated with the different services we provide.
I think one important question we should get in, since we're actually reaching the end of our 1 hour webinar, especially since we have you here, Jason, as both trauma surgeon and as C-suite representative, is the idea, what does the C-suite actually know about us as acute care surgeon, what we do, and what do they think of us? I think that is, you have the unique perspective since you've got your legs in both, and what can you tell us about that?
Well, well, the answer becomes as shortly as they're as scared of us as we are of them. It's a little bit of the wild animal scenario. And I mean that in the best possible way. And what I mean is one, they sometimes fundamentally don't understand the operating rooms. They sometimes don't fundamentally understand the flow of patients, particularly in traumas where we're accessing a lot of high cost, high resource services in order to affect a very small chance of quality survival. They understand it from, just, the personal level, but they don't quite understand how we do or why we do it. I also think that the reverse is also true, is that sometimes we come at the CEO or CFO kind of spectacly, saying they just don't understand what we do, or they just don't get it, or they're just bean counters, or they just care about the money. And I remind people, look, if you only care about the money, there's a lot better ways of making money than working in a hospital system, particularly these days. And that everyone who goes into healthcare from the business side or the clinical side, they fundamentally go into that because they're trying to provide for a patient or provide services for a patient or help their community or whatever. They all go into it with that nature. And I think, we have to sometimes take a step back and remember that. If you want to be a CFO of a hospital system, yes, you're coming at it from a finance side of things, but if you've got a great finance background and you're good enough to be a CFO of a large academic or healthcare organization or trauma system, you're good enough to make a lot more money on Wall Street or banking or something like that. You have to ask yourself, well, why are you here? And I think we're all here to help people. And I really do believe that, particularly if I've been in both sides of this. And I think from our perspective, reminding ourselves of that sometimes and not being so scared to have those conversations, invite people along. You'd be surprised how far you can go by inviting someone from the C-suite to come with you and see what life is like on the trauma service. Take them on rounds, have them in a trauma bay, or God forbid, take them in an operating room so they can see what it's like in there during a major trauma. It can be eye-opening, and it can absolutely reshape and change kind of their perspective and your perspective on what's going on, kind of thing.
Thanks. I think there's about like 15 more questions that I think we could ask you and that we had prepared. But we're also at the end of the webinar. So I would say this is a good time to end the webinar. I hope I see everybody at AAST, which is now coming up in just, 3 weeks in Boston. And especially anybody on the call here, if you're there, find us, ask questions. I think we could spend a lot more time talking about the topic in general, be it about acute care surgery and where we're going, and also those specific questions of how do I demonstrate the value to my administration. But I think we just really started the discussion today, got a couple of good insights, but this is an overview, and to go into detail takes a lot more time, and hopefully we have more time for that and opportunity at AAST.
Absolutely. And like I said, hope to see everybody there. Feel free to stop me in the hallway and ask questions. I'm always happy to talk.
Awesome. Thanks so much, Jason. Thank you so much for joining us for this. Trisha, thanks for co-moderating and presenting, and thanks to the AAST for hosting us, and thanks for everybody to calling in there. It should be on the website as recording. I think at some point you'll get an email from AAST. And thanks again for joining us today. Good night, everyone.
Thank you, everyone.
Night, everyone.